All right, class. In today's lecture, we're actually going to start looking at the microscopic anatomy of hyaline cartilage and this type of connective tissue. When we look at the structure of hyaline cartilage, we're really looking at a collection of cells that are really scattered throughout a matrix of a bunch of different protein fibers. And so we're going to find that these cells are embedded in a gel-like, what we call ground substance. And this ground substance is going to include a lot of different types of proteins, typically called proteoglycans, but oftentimes not calcium. It does add a resilience and flexibility to the structure. And when we look at particularly this ground substance, we're going to find that it's got a very high percentage of water. And so because of this resiliency and flexibility, and also this increased amount of water, we're going to find that it's a very good shock absorber and highly resistant to compression type forces. The one downside is that it is avascular, which means it has no direct blood supply, and also contains no nerves. Okay, so there are no nerves involved with the actual cartilage itself, and there are also no blood vessels. Now, when we start looking at the different types of cells, one of the types of cells that we look at with hyaline cartilage is called a chondroblast. Now, whenever you see that term or that prefix called chondro refers to cartilage. And so a chondroblast, just like an osteoblast is kind of our bone-forming cell, a chondroblast is also kind of our cartilage-forming cell. And so what a chondroblast does is it produces our cartilage matrix. Our chondrocytes then are essentially chondroblasts that become encased within the matrix. And so we basically look at our chondrocytes as mature chondroblasts in a sense. These chondrocytes are going to occupy very small spaces called the lacunae, and they are going to help maintain the matrix of this particular cartilage substance. We also have what we call a perichondrium. And this perichondrium is a very dense, irregular connective tissue that basically goes around and covers the cartilage to help maintain its shape. So when we look at cartilage, we really have to look at the growth of the cartilage. And so the growth of cartilage really is beginning during the embryonic development of your body. The growth in length is actually going to go through a process called interstitial growth. And so what we're going to find is it's going to occur within the internal regions of the cartilage. We also have growth in the width of the tissue, and this occurs by appositional growth. And so appositional growth actually occurs on the cartilage's outer side or outer surface or outer edge. So here we look at interstitial growth. And again, I know these graphics may be hard to read. So again, make sure that you kind of look at your book. But this graphic really just kind of goes through the phases. So you see here that a chondrocyte within the lacunae begins to exhibit different mitotic activity. So basically, we are going through the process of dividing these cartilage cells. So the two cells now called chondroblasts are produced by mitosis from one individual chondrocyte, and they do occupy one particular location within that lacuna. Each cell produces new matrix and begins to separate from its neighbor. Each cell is actually now called a chondrocyte. And so once we have the two new cells, the cartilage then continues to grow internally. Now let's take a look at appositional growth. So we take a look and we see that we have mitotic activity that's occurring in the stem cells within that perichondrium. We then see that we have undifferentiated stem cells and committed cells that differentiate into chondroblasts. The chondroblasts then are able to produce new matrix at the periphery. As a result of creating that new matrix on the periphery, we start to see the chondroblasts push apart, and those chondroblasts are now becoming chondrocytes. And those chondrocytes continue to produce more and more matrix at the periphery of the tissue. And that's how we're able to grow our cartilage more from the outside as opposed to from the inside of the tissue. So now we get into ossification, or what we call osteogenesis. And this is basically what we would call bone formation. And so we form our bone and develop our bone from a base type of connective tissue. And normally this is going to be some sort of hyaline cartilage template. It's going to begin in the embryo and really continue all the way through childhood and adolescence. And it really occurs all the way up to adulthood. And there will be some continuing of this growth through adulthood, and we'll talk about what that type of growth actually is. We'll typically see this begin through by the 8th through the 12th weeks of embryonic development, and this is where we start to see the skeleton begin forming. Now, it does this through a process of intramembranous ossification. We also have a second type called endochondral ossification. So two different types of bone formation, and we'll talk about both of those. So with intramembranous ossification, we have bone growth that occurs within a membrane. We can often, or you may oftentimes hear this called dermal ossification. And this is the way that we really produce a lot of the flat bones of the skull, a lot of our facial bones, the mandible, and the central part of the clavicle. So when we look at the steps of intramembranous ossification, we have an ossification center, which is basically the major point or the major region where the bone begins to develop. So this ossification center forms within the thickened regions of a type of tissue called mesenchyme. We're going to see some of our cells become osteoprogenitor cells, and some of the cells are going to become osteoblasts. And again, we'll have these osteoblasts begin to secrete this osteoid matrix. The osteoid will undergo a calcification as it goes from kind of a more liquid substance to a hardened substance. And it does this by having calcium salts deposited into the osteoid. And as this happens, these calcium salts begin to crystallize. And as they crystallize, they start to entrap the different cells. Particularly, again, these osteoblasts. And as the osteoblasts begin to become entrapped, they now become osteocytes. So now we start to develop what we call this woven bone. And this woven bone is kind of this trabeculae, this spongy bone type of bone. So at first, the bone's really immature and really is poorly organized. But as we start to see the woven bone pattern develop, that mesenchyme that surrounds the woven bone forms our periosteum. And if you remember our periosteum, it's really that kind of outer surface of the bone tissue. We then get what we call a secondary type of bone, and that's called lamellar bone. And lamellar bone really replaces our woven bone. So now we begin to form our compact and our true spongy bone. And they do this from the trabeculae that is actually being formed. The typical structure of a flat cranial bone is oftentimes what we see in this process. It's composed of two external layers of compact bone with one layer within it of spongy bone. So here's our graphics of our intramembranous ossification process. So again, we see this ossification center that develops in this mesenchyme tissue. You'll see that the osteoblasts are able to kind of develop this or secrete this osteoid, and this osteoid really begins to undergo the calcification process, where now it traps some of the cells inside and they turn into osteocytes. Here you begin to start to see the woven bone pattern, or this primary bone, and it really starts to form the periosteum. And so you start to see the trabeculae being formed. This is more of a hardened type of bone tissue. And so you're starting to see this woven pattern, this trabeculae beginning to form. We then see the lamellar bone that replaces the woven bone, and the compact bone edges are now beginning to form. So you see the compact surface on one side and a second side, and then you see this middle, this spongy bone. And remember, in flat bones, this is called diploe. Our second type of ossification is called endochondral ossification. And so endochondral ossification, instead of really forming from kind of a ligamentous or fibrous type of template, it actually begins from a hyaline cartilage template or model. And this is really the way most of the bones of the skeleton are formed. And this is how we really form the upper and lower limbs, the pelvis, the vertebrae, and then the ends of our clavicles. An example of this process is really what we see with long bone development, particularly, again, the bones of the upper and lower limbs, so the humerus and the femur in particular. So when we look at the steps of long bone development in a limb, we again really start with this hyaline cartilage model within the fetal tissue. Our chondroblasts secrete the cartilage matrix, again, starting around that 8th to 12th week of development. Our cartilage then begins to calcify, and we start to see what we call a periosteal bone collar. And so we're taking this cartilage template and really starting to surround it with a collar of bone. The chondrocytes in the cartilage model then produce holes within the matrix. The matrix calcifies, and the chondrocytes actually begin to die. And as our chondrocytes die, it helps to produce this calcified cartilage shaft with these larger holes in it. These large holes really allow blood vessels to grow toward the cartilage, and our osteoblasts, again, our bone-forming cells, develop and secrete this osteoid. This osteoid, again, is the secretion that begins to calcify and really give us kind of that bony tissue. So it forms a layer of osteoid around a calcified cartilage shaft, and this periosteal bone collar is formed. We then develop what we call a primary ossification center, and it's going to develop in the diaphysis, which again is the shaft of the bone. It develops what we call a periosteal bud, and this periosteal bud extends from the periosteum into the cartilage shaft. This is where we have the growth of capillaries and the growth of our osteoblasts. So again, now we get to the osteoblasts, and they're continuing to produce this osteoid on this calcified cartilage template. And so we have this primary ossification center now that's beginning to develop. And this is the first major center of bone formation. And again, oftentimes occurs right around that 12th week of development, or very late into the first trimester. The bone development extends in both directions towards the epiphysis, or towards the ends of the bone, and the bone connective tissue actually gets displaced as it calcifies and really starts to degenerate the cartilage. We then develop a secondary ossification center, and these secondary ossification centers are going to form in the epiphyses. So now we have this hyaline cartilage that calcifies and degenerates, or wears down and degrades. The blood vessels continue to enter at different locations, as well as entering the osteoprogenitor cells. This helps to form our secondary ossification center. And again, the bone displaces the cartilage, and not all of these secondary ossification centers are formed at birth. Many of them occur as we go through childhood, as we continue to lengthen and get our bones to add height and width. So there's a lot of different centers that are forming after birth. Osteoclasts then also are involved, and they help to resorb some of the bone matrix that is created. And what these osteoclasts do then is, as they resorb this bone matrix, it actually helps to create our hollow medullary cavity. So from here then, the bone begins to replace the cartilage, except at the articular ends, so at the articular cartilage, as well as the epiphyseal plates. The epiphyseal plate is going to remain cartilage, and that is going to be what we know as our growth plate. The epiphyseal plates ossify, and they form these epiphyseal lines as we continue to grow and as we begin to close off those growth plates and those growth centers. So lengthwise bone growth actually continues all the way into puberty, where essentially you get to a point where you've reached your adult height. Growth will continue until those epiphyseal plates are closed and then converted to what we call these epiphyseal lines. And this indicates the bone has reached its adult length when those epiphyseal plates close. This oftentimes occurs at a wide range of ages. Sometimes it's age 10. Oftentimes this is with some sort of genetic deformity or some sort of genetic disorder, or all the way up to age 25. So here's what we look at when we look at endochondral ossification. So here we start off with this hyaline template. And so this is basically hyaline cartilage. Once we get into step 2, then we now start to see this bone, this periosteal bone collar. So now we have the deteriorating cartilage within the what's turning into the shaft of the bone. The periosteal bone collar forms around the diaphysis. So now we have the diaphysis here, and you can see the eventual forming of the epiphyses. We get to our primary ossification center formation, and that's going to occur within the diaphysis. So it occurs really within the shaft of the bone. But now you can see where we're starting to have these blood vessels form and develop. You can also see that within the epiphyses, you can start to see some blood vessel formation there. That blood vessel formation then triggers the next centers. So now once we get into late-term development, or as you get into newborn and childhood age, you now start to see a lot of these secondary ossification centers beginning to develop. So now the shaft of the bone is going to continue to grow lengthwise, and we're going to see this continuous growth of these epiphyseal secondary ossification centers. As we get into childhood then, again, we're continuing this lengthwise growth. So the bone replaces the cartilage, really except at these two locations. The epiphyseal plate, where we're going to continue to have growth, and the articular cartilage. So articular cartilage basically is the remnants of the hyaline cartilage template. So remember that hyaline cartilage is the original type. Articular cartilage is what we call the leftover at the articular surfaces. And then once we get into adulthood, you're going to see that these epiphyseal plates begin to close, and this is where what we call the epiphyseal line. And again, if you remember back into the first part of this chapter, this is the region of the metaphysis. And we have the articular cartilage still on the surface in the epiphysis, and here's our final, essentially fully grown bone in shaft in the metaphysis area. So as we continue to go through growth, we also have what we call interstitial growth. Now, interstitial growth is dependent upon cartilage growth within the epiphyseal plate. And so when we look at the epiphyseal plate, we really have what we call, or what we consider, 5 zones within that epiphyseal plate. We have the zone of the resting cartilage. The zone of the resting cartilage is going to be the zone that's nearest to the epiphysis. Now, these are going to have a lot of our smaller chondrocytes that are distributed throughout the matrix. They're going to resemble mature hyaline cartilage, and this resting zone really secures the epiphysis to the epiphyseal plate. Our second zone is the zone of proliferating cartilage. So in this zone, the cells or chondrocytes are really undergoing rapid mitotic division. And so they are actually proliferating in this region. They're going to line into the longitudinal columns of flattened lacunae, and these columns are parallel to the diaphysis. Our third zone is the zone of hypertrophic cartilage. And if I believe we've talked about this before, but we talk about hypertrophy and atrophy. With atrophy, that means something getting smaller. Typically, we refer to muscle atrophy. Muscle gets smaller. With hypertrophy, the muscles are getting bigger. So in this case, we have cartilage hypertrophy. And so here we have the chondrocytes are no longer developing and dividing, but now they're actually beginning to get larger. So now they're going through hypertrophy. And so the walls of the lacunae actually become a little bit thinner. Our fourth zone is a zone of calcified cartilage. Now, the zone of calcified cartilage is composed of 2 or 3 layers of chondrocytes. And we start to see different minerals being deposited between the columns of these lacunae. And during this phase, or within this zone, we start to see the destruction of our chondrocytes. And that leads us into then the zone of ossification. So now the walls break down between the lacunae and the columns. The spaces are invaded by the capillaries and the osteoprogenitor cells. And now we have new bone matrices deposited on this calcified cartilage matrix. And so now we're beginning to calcify this particular zone of the cartilage region. So if we take a look at the epiphyseal plate, again, we start at the area that's closest to the epiphysis, and then we have the area that's closest to the diaphysis. This is our zone of resting cartilage. So again, not a whole lot is happening here. Here we have our zone of proliferating cartilage, where these cells are really starting to divide and create more. Here we have our zone of hypertrophic cartilage, where now those cells are actually getting larger and bigger. Our zone of calcified cartilage, where we're starting to calcify this cartilage matrix. And now we start to see where these cells are being killed off. And now we start to ossify this tissue, and it's becoming, in this particular case, a part of the shaft of the bone. And this kind of indicates how we grow from a length perspective. So when we look at bone growth in length, this occurs specifically within zone 2 and zone 3. Again, zone 2 is that proliferating where the cells are dividing, and zone 3 is the hypertrophic cartilage region. So this is where those cells are actually getting larger. And so what it does then is it pushes the zone of resting cartilage towards the epiphysis and ossifies in zones 4 and 5. The epiphyseal plate then maintains its thickness throughout childhood and during childhood. And then as we mature, that rate of cartilage production begins to slow down. And so the rate of production can't keep up with the rate of ossification. And so finally we get where the epiphyseal plate ossifies, and the remnant of that epiphyseal plate is an internal thin line of compact bone called the epiphyseal line. This is just kind of a colorized x-ray of a child's hand, where again, you can actually see the bone, and you can see the layers or the zones where these growth plates are located, both in the arm bones and the wrist, and then you can also see through the metacarpals as well as the phalanges up through the hand. So when we look at a clinical view, we kind of look at a lot of forensic anthropology. And so anthropology really looks at bones and joints of individuals, different ages, different sexes, and it allows us to really understand what happens when people either are killed or there's some sort of death and skeletal remains are found. It gives us the ability to really study these. So the juvenile skeleton will separate or have separate diaphysis and epiphyseal regions, whereas the adult skeleton is going to have whole fused bones. And again, this really helps to determine the age of the skeletal remains that we may be studying. If we look at an open area, that means there's no union between the epiphysis and the other bone end. If we have a partial union, that means there's some fusion between the epiphysis and the rest of the bone. And if we have complete union, That means we have all visible aspects united are to the rest of that bone. And so by looking at these three characteristics really allows us to kind of put an age range to the skeletal remains. Now, understand though that female epiphyseal plates fuse about 1 to 2 years earlier than males. It's why oftentimes females, as we develop, you'll often see that women will develop a little bit faster, particularly as you get into junior high, kind of that 6th, 7th, 8th grade area or range. And then usually men will start to catch up, usually towards the 8th grade to freshman to sophomore aged years. You'll typically see men, or I guess young boys at that point, really begin to take kind of their growth spurts. So our second type of bone growth is appositional bone growth. So with interstitial, we're kind of growing lengthwise within the bone. Now we're looking at, in a sense, growing outwards. So we're growing widthwise. So appositional bone growth is going to occur within the periosteum. The bone matrix is going to be deposited within the layers parallel to the surface. And then we also have osteoclast activity. And so osteoclasts, remember, kind of destroy bone. What they do is they reabsorb different bone matrix regions along the medullary cavity. And this allows us to start growing outwards. And so you see within an infant here you have your medullary cavity, your periosteum along the outer surface, and then here's this compact bone area. When you get into the child's bone, you'll start to see that we're having an area through here that's actually being resorbed or broken down. And so we have areas of osteoclast activity, and then out here around the compact area, we have bone being deposited in this area. And so now once we get to a young adult, that process continues until we get to an adult bone. So if we look at another clinical view, we look at what we call achondroplastic dwarfism. So achondroplasia is characterized by the abnormal conversion of hyaline cartilage to bone. And so the most common type of this condition is called achondroplastic dwarfism. And this is where we have long bones of the limbs really stop growing in childhood, and other bones are going to continue their normal growth. So what ends up happening then is we typically have kind of a short stature but large head, because again, most of the limbs kind of stopped growing, but the rest of the body continued. This typically causes a failure of the chondrocytes in the epiphyseal plate to grow and enlarge, and so you essentially have inadequate endochondral ossification. Now, one of the other things that continues as far as bone formation is what we call bone remodeling. Now, bone remodeling continues throughout adulthood, and it's going to occur at the periosteal and the endosteal surfaces of bone. And it is going to occur at different rates. So the distal part of the femur, we really consider being replaced every 4 to 6 months based on bone tissue being broken down, but then also being added again. So cells really replace themselves every 4 to 6 months. The diaphysis of the femur is really not completely replaced at all over a lifetime. So it's basically continuing to add and remodel without really being replaced. On average, we really look at about 20% of the skeleton is being replaced yearly, but it is dependent upon the coordinated activities of osteoblasts, osteocytes, and osteoclasts. And it's also influenced by different hormones throughout the body, but also by mechanical stressors. So as we look at bone remodeling in response to mechanical stress, this is really something that is occurring essentially every day of your life, because it really occurs in weight-bearing movements and exercise. Now, mechanical stress is required for normal bone remodeling. It's detected by the osteocytes and is communicated to the osteoblasts. And by communicating this information to osteoblasts, it helps to increase the synthesis of our osteoid, which is kind of that matrix of the bone tissue. It leads to increased bone mass, particularly in the weight-bearing bones, and as a result of our weight-bearing activities. Now, if we look at decreased bone mass, we often are going to see bone is being removed because of mechanical stressors. And oftentimes it actually is being removed because of a lack of stress being placed upon it. So that leads us to what we call Wolff's Law. Now, Wolff's Law is when a bone grows or remodels in response to the forces or the demands placed upon it. Now, there's a lot of different observations that we see that help to support Wolff's Law. Before I get into Wolff's Law, let's make that our code word for the day. So the code word for today's attendance is going to be Wolff's Law. Okay? So now let's look at some of the observations in Wolff's Law. So when we look at people, whether they're right-handed or left-handed, we're often going to see that dominant side, typically resulting in bone of that upper limb being thicker and stronger. Again, when we look at Wolff's Law, it's based on the forces or demands placed upon it. If you're right-handed or right-footed, oftentimes you're going to notice that that side tends to be a little bit stronger. And we're often seeing that not only are the muscles a little stronger, but because they're putting more force, because you're using it more often, you're putting more stressors on the bones of that limb. And so again, they become a little bit thicker and a little bit stronger. And I'll come back to a specific example of something very similar to this. We also are looking where curved bones, they're normally going to be thickest where they're actually most likely to buckle. So if we look at a rib, rib has this kind of curved shape. And so if you take the two ends of the rib, that means as you start to bend them together, it's most likely to buckle between the two ends, so right towards the middle. And that's typically where we actually see the bones of the ribs are a little bit stronger and a little bit thicker because they are trying to protect that particular structure. The other thing that we see is that trabeculae are going to form along lines of stress. Again, when we look at these structures, the more stress we have on the tissue, the more trabeculae we're actually going to form. So more of those pillars and columns the body is going to put down, in a sense, trying to strengthen that particular area. And then number 4, we start to see large bony projections are going to occur where heavy active muscles attach. So now when we look at this, when you look at the bones, particularly if you're in lab, whether you're in lab or whether you're looking at it on a computer online, you're really going to be seeing all these different areas and projections and things and ridges and all different types of structures where oftentimes we're going to see muscles attaching to it. And we see this because as those muscles attach and as the muscle and tendons really start to pull on the bone, it really puts a lot of extra stress. And that's where bone starts to develop a little bit more. And that's where we start to see a lot of these projections. Now, I said I would come back up here. One of the best examples that we see with this type of, it may not necessarily be handedness, but what we do see with bones becoming thicker and stronger, and this can be developed, is oftentimes with martial arts. So if you've ever watched the Karate Kid Part 2 when they are over in Okinawa, one of the things that you will have seen is Mr. Miyagi's best friend has the piece of driftwood that he's basically put between two pillars. And one of the things that you'll see him doing is he'll be in his particular stance, and he'll constantly be coming straight down on it with his hand. Now, doing that for a day doesn't make a difference. But when you do that over the course of years, and in their case, decades, you really do begin to develop more bone development and more bone being put down in those particular areas. And so studies have actually been done on martial artists, both on their hands as well as on their legs, because they'll do the same thing with their feet and their shins, they'll basically kick it against something that provides resistance. And those studies indicate that the extremities or the bones in the extremities of martial artists that have been doing it for years and for decades oftentimes are significantly stronger. The bone tissue is stronger than an average individual. And oftentimes that's what we refer to when we say the hands of a martial artist become lethal weapons. Yes, because of their technique, but also from a physiological and an anatomical perspective where they really do have stronger bones. And this is actually shown by a patient of mine who is a martial artist. I actually ran into him one day outside his dojo, and he basically was taking a piece of wood or rolling pin basically and rolling it up and down his shins, essentially for the same purpose, making that particular bone stronger by putting a force upon it. So not only do we have the mechanical stresses, but we also have different hormones that are going to add strength to bone. These hormones are going to be essentially molecules that get released from one cell into the bloodstream. And they're going to travel throughout the body and they affect different cells. But what hormones do is when they get to specific cells, they actually bind to cellular receptors that have very specific receptors on them for these specific hormones. And what we call these hormones when they attach to these receptors are called ligands, which again, we've talked about this when we talked about our channels, specifically our ligand-gated channels. Basically, ligands are any chemical that comes in that's very specific to those receptors. And so these hormones can initiate specific cellular changes. And by initiating these cellular changes, they can actually alter the rates of chondrocytes, osteoblasts, and osteoclast activity. So we can change how much bone we're putting down, or how much bone we're breaking down, or how much chondrocytes, how much activity we have on the matrix that they're utilizing. And so what this does then, it affects bone composition as well as the growth patterns. So if we look at a couple of these, one of the first hormones we look at is called growth hormone, or somatotropin. And it's going to be produced by the anterior pituitary gland. And what somatotropin does is it stimulates the liver to produce another hormone. And the secondary hormone is called somatomedin. And both of these hormones directly stimulate the growth of the cartilage within the epiphyseal plate. And this is oftentimes what is given in children that may have some growth issues. They try to stimulate the growth by giving growth hormone. We also have the thyroid hormone. Now, the thyroid hormone is secreted by the thyroid gland, and it's going to influence the basal metabolic rate of bone cells, and it regulates normal activity at the epiphyseal plates. A couple of the other hormones that help develop or influence bone growth is going to be our sex hormones. And these are estrogen and testosterone. And these are going to be secreted, obviously, in large amounts as we get to puberty, and they dramatically accelerate bone growth. And this is where you start to see a lot of growth spurts. It helps to increase the rate of cartilage growth and bone formation within the epiphyseal plate. And bone formation rate is actually greater than the cartilage growth. And at this point, when we get bone formation greater at a rate greater than cartilage growth, this is where we begin to fill in that epiphyseal plate. And this is where cartilage eventually is replaced with bone and growth stops. So, how do we regulate the calcium concentration in blood? Well, regulating calcium is essential because what it is responsible for or required for is the initiation of muscle contractions, exocytosis of molecules from cells, including our neurons. It's also involved in the stimulation of the heart by the pacemaker cells, as well as blood clotting. Now, the two primary hormones that help regulate blood calcium are going to be calcitriol and the parathyroid hormone. So as we look at the hormonal control of blood calcium levels, one of the things that we're looking at is the parathyroid hormone. And so as we look at whether blood calcium levels increase or decrease, kind of helps determine whether or helps determine what a hormone is actually going to be stimulated or going to be released. So when the body starts to detect a decrease in the blood calcium levels, the parathyroid glands actually begin to release the parathyroid hormone, or PTH. This PTH actually stimulates our osteoclasts, and those osteoclasts begin to come in and start to break down bone tissue and degrades the bone matrix. As our bodies do this and these cells do this, it begins to release calcium back into the bloodstream. And as calcium is released back into the bloodstream, then we'll see that our blood calcium levels begin to increase. So when we also then look at calcitonin, calcitonin aids in the regulation of blood calcium levels as well. It has a little less significant role than PTH or calcitriol. Now, calcitonin is going to be released from the thyroid gland, and it's going to be released in response to high blood calcium levels. And so it kind of has a reverse response in a sense than what our parathyroid hormone does. It's also secreted in response to exercise, and it inhibits osteoclast activity. So with calcitonin, we're obviously going to inhibit the osteoclast activity, which helps to increase blood calcium levels. And so in this case, what we're typically going to see is an increase in osteoblast activity. It stimulates the kidneys to increase the loss of calcium in the urine, and this also stimulates the reduction in blood calcium levels. We typically are going to see the greatest effect during the greatest bone turnover, which in the case of children is going to be our best example. So let's take a look at the effects of aging. Now, aging is going to affect bones in two different ways. One, it's going to decrease the tensile strength of bone, and it does this through a reduced rate of protein synthesis by our osteoblasts. We're going to see a relative amount of inorganic material being increased, and this overall causes the bone to become a little bit more brittle and more susceptible to fracture. We can also see where the bone has a loss of calcium and other minerals. And this typically results in a bone that's thinner and weaker. We're going to see an insufficient ossification level, and this is going to lead to osteopenia. Now, with osteopenia, it's going to occur slightly in all people with age. We're oftentimes going to see it begin around the age of 35 to 40, although it can begin a little bit later in life. We're going to see a situation where osteoblast activity declines, but osteoclast activity maintains previous levels. And so as osteoblast activity declines, which are our bone-forming cells, but osteoclast activity maintains normal levels, we're going to see a situation where a lot of that bone density now begins to decrease. We're going to see it in the vertebrae, in the jaw bones, and then we're also going to see the epiphyses are going to lose large amounts of mass as well. We'll see a situation where women tend to lose more of their skeletal mass every decade than men. Now, with osteoporosis, we have a situation where a reduced bone mass amount is sufficient to compromise normal function. And it's going to occur in a significant percentage of older women. And it occurs then in a smaller percentage of older men. But one thing we do see is we often see a variation or a change in hormones as people get older. Vitamin D levels begin to decrease. Growth hormone decreases. Estrogen and testosterone levels are lower. All of these things then contribute to a reduction in bone mass. So what ends up happening then is this results in decreased bone mass, which helps to weaken the bones, and this makes them more prone to fracture. Oftentimes, this is obviously linked to age, We are going to see it at the onset of menopause, especially because, again, it is more prevalent in women. We do see it in more of with smoking history, and we also see it more prevalent in the Caucasian race. Postmenopausal women tend to be at most risk, again, as we're looking at the onset of menopause. The increased incidence of fracture increases, again, because we're really looking at a weakened bone structure. Again, because we see this oftentimes in the epiphyses of bones, we're going to see it more prevalent in the wrist. We're going to see it more prevalently in the hip, especially near the femoral head, as well as we get into the vertebral column, and we're really starting to look at the bodies of the bones, where we're really looking at compression fractures. Now, the best treatment for osteoporosis really is prevention. And we do this oftentimes with diet, so making sure that we're getting enough vitamin D, calcium, phosphorus, magnesium into our diets. But more importantly, or maybe more importantly, is going back to what we talked about with Wolff's Law and really looking at the stresses placed upon the body. And this is going to require physical activity in young adults. So making sure that we're very active, our bones are growing, our bones are getting stronger, and this can help to slow down or prevent osteoporosis from really developing as early as what it sometimes does in people. Some of the medical treatments involve doing things to try to slow the rate of bone loss and attempting to stimulate new bone growth. Now, there is some medications that we obviously can utilize, but again, sometimes the best treatments really is using what the body naturally does in our favor, which again tends to be more of the physical activity and exercise. So this is just an example. Again, when we look at an x-ray, here, as you can kind of follow my pointer, this is going to be the cortical edge, and you normally do see a little bit more of a wider surface here, but you can also very easily in through here see this medullary cavity. Now, it shouldn't be quite that pronounced, and especially as we get up into the greater trochanter and the femoral head and the femoral neck through here, you really shouldn't see quite this darkened color. This indicates essentially a loss of bone density, and this individual is a little bit more prone to fracture in this region. This is a pelvis image that does show both sides of the hips. And again, it may not be the best quality. It was just one of those images that was pulled off the internet there for reference. And so you may not necessarily see it quite as pronounced here, but you can definitely see this black area or significantly darker area as in relationship to some of the cortical edges. And again, this individual is more prone to fracture, especially through the femoral head and the femoral neck region. But then you can also see some of the decrease in bone density up here through the pelvis. So another clinical view is going to be rickets. Now, rickets is really a childhood disorder, and it's caused by a vitamin D deficiency in these children. We'll see a characterized by a deficient calcification of the osteoid tissue, and we're oftentimes going to see kind of this bow-legged appearance, again, because as children develop, they didn't have enough vitamin D, they didn't get enough calcification of the bones at the right time, and so essentially we're looking at a situation where we were trying to put a lot of weight on essentially cartilage templates. And so we see these disturbances in the growth of the bone, which leads to hypocalcemia and can oftentimes lead to tetany, which is cramps and twitches, which is also then caused by low blood calcium levels. We are oftentimes going to see this occur in some of our developing nations where nutrition isn't quite as significant. And we have started to see an incidence that's increasing in some urban U.S. children, again, as certain conditions are met, and we start to see maybe a decrease in nutritional components that some of these children are getting at a younger age. And so this is just kind of an image of what we see with rickets. Again, you can kind of take a look and you're able to see the bow-legged appearance of this particular child. Again, it's basically a situation where the bones never had a chance to really calcify at the right times as the child was developing. So let's take a look at bone fractures. Now, obviously, a fracture is a simple break in the bone. Now, we do have several different types of fractures, some a little bit more specific than others. We first look at a stress fracture. Now, a stress fracture is a thin break that's actually caused by physical activity. Oftentimes, we can't really see it on X-ray, but we do see it on MRIs and bone scans. We can also have a pathologic fracture. Now, a pathologic fracture isn't necessarily one that's caused by physical activity, as it's actually more caused by bone that's really weakened by some sort of disease. We often see this actually in, or do see it sometimes, in bones that may have some sort of bone tumor that's weakened the bone. And that may, in some cases, be the reason you catch or see the tumor itself. We can have a simple fracture. And a simple fracture is simply where the bone is broken but does not penetrate the skin. Whereas then we also have a compound fracture. And a compound fracture is where one or both ends of the bone that's broken actually pierces the skin above it. So as we look at bone fractures, we really classify them by 4 either-or classifications. And they're relatively simple as far as how we go through the classification process. So 1, we look at the position of the bone ends after fracture. We can either have a non-displaced or a displaced fracture. With a non-displaced, the ends actually retain their normal position. So we don't really have to go in and do any setting per se. Whereas with a displaced, the bones are actually out of alignment. And we now do have to go in, kind of reset the bone before you go through any casting process. We can also classify them based on the completeness of the break. With a complete fracture, the bone is broken all the way through. With an incomplete fracture, it's not broken all the way through. We can also classify a bone fracture based on the orientation of the break to the long axis of the bone. We'll oftentimes see this type of classification when we look at the long bones, so the femur and the humerus. We'll have a linear fraction, which is going to be parallel to the long axis of the bone, or we can have a transverse fracture, which is going to be perpendicular to the long axis of the bone. Our 4th classification is whether or not the bone ends penetrate the skin, which both of these we've touched on. We can have a compound or an open fracture where the bones do penetrate and break the skin, or we can have a simple or a closed fracture, which is the most common, and the bone ends do not penetrate the skin. So here we kind of have an overall list of a lot of different classifications or special type of fractures. For the most part, you do kind of want to have a good idea of what most of these are. Oftentimes, the description of the classification really tells us exactly what it is. If we look at a complete, we talked about that. Compound, we talked about that. A compression fracture is really where the bone is squashed or compressed, such as what we see with a compression of a vertebrae, particularly in the lumbar spine during a type of fall. And you see this, what we call pancaking of the vertebrae, where the bone or the vertebrae above it and below it basically compressed it on top of itself. Again, we talked about an epiphyseal fracture. These are Salter-Harris type fractures, and these can be based on where the fracture starts and where it goes, whether it goes through the epiphyseal plate, stays in the epiphyseal plate, crosses the epiphyseal plate, all gives us a different type of fracture. A green stick is a really good description of a fracture that we often see in younger children, mainly because the name itself really tells us exactly what it is. When you think about a twig or a branch and you try to break a dead one, essentially it snaps and it breaks. But when you think about one that is relatively fresh and just off of the tree, you'll notice when you try to break it, the bark may kind of break and fray, but you still have kind of the chlorophyll or the inside that's still intact because it hasn't died off. And this kind of bowing or fracturing on one side is what we call a green stick fracture. We have a partial fraction where one side of the bone breaks and the other side is simply bent as opposed to completely fractured. A hairline fracture, again, is a very small or fine one. Impacted is where one fragment of the bone is firmly driven into another. A spiral fracture is where the fracture actually spirals up the bone itself. Stress fracture we talked about. Transverse fracture, you can see how it basically goes straight across. So all of these, you'll want to have a pretty decent idea of what they are. But again, most of the names really kind of tell the story of what type of fracture it is. So how do we go through fracture repair then? So these really are the 4 stages of fracture repair. And we'll go through each one of these here. So with our first stage, we have a fracture that actually occurs. So in the typical process of a normal simple fracture, the complete process really takes about 2 to 3 months to heal. Normally, it's more on the line of 2 months to really have it healed up, but then we still have about another month really where we go through a process called remodeling. Now with a compound fracture, it does take a little bit longer. Now there are 4 steps in the process of repairing a fracture. So as we go through the fracture process, we obviously have a break in the bone. So once we have a break, we're actually going to form a hematoma. And this forms from clotted blood. And so you see this blood as we break the bone, we bust the blood vessels open. And so now we have this accumulation of blood in and around the area. And that's going to contribute to some of the swelling that we normally see with a fracture. So the blood vessels are torn within the periosteum and blood begins to accumulate. The second step in fracture repair is where we have the fibrocartilaginous callus beginning to form. So you'll start to see that the hematoma reorganizes into kind of a connective tissue procallus. We have fibroblasts in here that are actually producing a fibrous material called collagen. And so we're creating this collagen fiber that starts to attract the ends of the bone. Our chondroblasts also come in here and form a dense, regular connective tissue within that area. And the procallus then becomes a fibrocartilaginous, or what we call a soft callus. Remember, this is fibrous material and cartilaginous material. So it's more of a soft callus. With a hard callus, now we're getting into the bony component of the healing process. So now we're forming the hard or the bony callus. Our osteoblasts that are adjacent to the callus begin to produce our trabeculae. And you can start to see this woven bone pattern of trabeculae in here, the pillars and the supports. This is actually going to replace the callus, and it forms what we call the bony or the hard callus, as opposed to the fibrocartilaginous callus that we just had in phase 2. We're going to see a situation where now this bony callus begins to thicken and grow, and you can also see where it starts to bulge out a little bit on the sides, right where the fracture actually took place. And then phase 4 is where we go through a process known as remodeling. And remodeling is the final phase, and it's where the osteoclasts remove any excess bony material. So if I scroll back to phase 3 and we have this bony material that's occurring or developing on the outer surface of the bone, in phase 4, we start to see where that excess bone material is now being removed by these osteoclasts. Now we start to see where the compact bone replaces the primary bone, and you'll see that we kind of develop the rest of this medullary cavity as the remainder of the blood vessels are fused. And this can actually leave a slight thickening of the bone at that location. Okay. And so oftentimes this will lead to a region that's actually stronger than what it was prior to the fracture. And this will end up being the end of chapter 7. I'll have this uploaded and you'll be able to go ahead and watch it.